All right. Well, welcome everyone. We're going to get started here. Welcome to the National Fellows online lecture series. The topic we're going to discuss today is diabetes in athletes. And my name is Dana. I'm the Pediatric Sports Fellow at Northwestern and Lurie Children's. We'll cover some information and ground rules first. This lecture series is sponsored by the AMSSM Online Education Fellows Subcommittee, and is co-sponsored by the Education Committee and the Fellowship Committee. This is meant to serve as an adjunct to your individual program's education programming. It's meant to provide sports medicine fellows with direct access to educational experiences with experienced AMSSM speakers, and at times invited guest speakers in a variety of formats. And this is also meant to assist in CAQ exam preparations. So please mute your microphone and turn off your video. At the end, you'll be able to, you can submit throughout questions in the chat function. Feel free to include your name and program if you'd like. And then I, as the moderator, will ask the questions during the Q&A section at the end of the talk based on the questions that you submit. And after the program, please complete the evaluation, which will be put in the chat at the end of the lecture. So without further ado, I'd like to introduce you to our expert speaker today, Dr. Thomas Trojian. So he's the director of WellSpan Sports Medicine Fellowship Program and a professor at Drexel University College of Medicine. Before WellSpan, he was the fellowship director for the programs at Drexel, Tower Health, and UConn, the chief medical officer for Drexel Athletics, team physician for UConn, and has provided athletic coverage for numerous sports teams from the high school level to national and professional. His special interests include injury prevention, sports ultrasound use, running injuries, and concussion prevention. He takes a holistic approach to medical problems and is a strong proponent of exercise as medicine. He served on the sports medicine advisor to the Connecticut Interscholastic Athletic Conference, was on the board of directors for AMSSM and the editorial board for Clinical Journal of Sports Medicine. And he's now on the board of trustees for ACSM and is section editor for Current Sports Medicine Reports. He's authored multiple Philadelphia Inquirer sports doc blog posts. He's active on Twitter. You can find him at ttsportsdoc, and has published on many sports medicine topics, including managing the athlete with type 1 diabetes. In his free time, he enjoys being active, maintaining a multi-year streak of 10,000 steps daily, doing triathlons and duathlons, hiking, including regularly completing portions of the Appalachian Trail, cooking, and making bread. So super impressive all around. With that, welcome, Dr. Trojian. Thanks so much for being here. I'll let you
I appreciate it. And thank you everyone for joining tonight. And what I want to do is we published a position statement on the care of the athlete and active person with diabetes, and I'd like to acknowledge my co-authors before I start. You'll see references throughout the paper, and slides that are not referenced are from the position statement themselves. Today, I'd like to talk to you about the list of benefits of exercise for type 1 and type 2 diabetes, why people should exercise, and explain the effects of exercise at different glucose levels. So part of the importance of a diabetes talk is actually an exercise physiology talk. And we'll go into fuel usage during exercise. We'll describe methods to prevent exercise complications, identify the symptoms of hypoglycemia, which are important, state the treatment of hypoglycemia, and then I'll give you some resources to look at the end. That's where we'll cover. Here we go. So active athletes and active people with diabetes can participate at all levels. And this involves people from weekend warriors, professionals, Olympic athletes, people who have even climbed Mount Everest with diabetes and needing insulin, so type 1 diabetics. So, we advocate that people with type 1 diabetes should be encouraged and educated by medical professionals to allow a safe participation in all forms of physical activity consistent with individuals' desires and goals. And the reason we say that is that there's a lot of fear in type 1 diabetics and families to not do exercise and activity for the fear of hypoglycemia. And so part of this is you can help. Physical activity provides many benefits, not just for hemoglobin A1C, but for cardiac reasons And so there's an extension of life in type 1 diabetics, not necessarily for the drop in hemoglobin A1Cs, but for the reduction in cardiac risk. So barriers to exercise are often, as I said, fear of hypoglycemia, loss of glycemic control, insufficient time, like most people, facilities or motivation, and a general scarcity of knowledge around exercise management. And so hopefully you as a physician can help guide people as you take care of them. In the United States, approximately 192,000 people have type 1, have diabetes, and 167,000 of type 1 and 20,000 type 2. Type 1 prevalence is high, at the younger ages, and of course, as type 2 diabetes increases as people get older, it drops. And overall, type 2 diabetes is 90% of people with diabetes, which is around 13.7 million people. That's a lot of people out of our 333 million people. One thing that I want to point out to you, when you look at what is the prevalence of type 1 diabetes in people who are 19 and younger, and it's about 3.2 per 1,000 people. And our college athletes, in one of our studies that I did, looking at the Colonial Athletic Association, what we saw was there was a 3.42 per 1,000. So there seems to be no difference in the general population as in the athletic population. And type 1 diabetes shouldn't prevent people from being able to exercise and be active, especially even at high levels. As you're probably aware, because you graduated med school, that type 1 diabetes is a chronic problem related to the absence of insulin. And type 2 diabetes is by far more prevalent, and it's more of a resistance to insulin. And often will have elevated insulin production. There are different combinations of the two, and there are other forms such as glucocorticoid-induced diabetes and gestational diabetes, which I'm not going to get into tonight. Some of the things you need to think about as you're managing, and I want to make sure we're all on the same page, is that, euglycemia with activity, the insulin decreases and counter-regulatory hormones go up, and we maintain euglycemia. Hypoglycemia is not necessarily too little glucose, but what it is an overabundance of insulin, and you have an increase in insulin and an increase in counter-regulatory hormones. Whereas in under-insulinized state, you end up with hyperglycemia, and so you have too little insulin. So those are the things you need to kind of think about as you manage people, that when they are at a lower state, they have a situation where they're having too much insulin, we need to gauge for that, and we'll see that as we go along. Another point that I need everybody to be kind of aware of is the GLUT4 receptors. So GLUT4 receptors are located in adipose tissue and striated muscles, cardiac and skeletal muscles. And they are a non-insulin dependent. And so they react to activity. They are part of the system with insulin, but they are very important for type 2 diabetics. They get upregulated with exercise. And so these are something that you need to be aware of, GLUT4 receptor. And GLUT means glucose transport. So, as we educate and talk to people about exercise and diabetics with exercise, we need to keep in our mind that we should be good examples of exercise. We should be out walking, should be active ourselves as physicians. Physical activity has both acute and chronic benefits. Providers should be aware of these to assist athletes as they become both safe and effective, and they can do these things. So what about exercise for prevention of diabetes? Well, there's a 6% decrease in age-adjusted risk for every 500 calories per week of exercise in a 1991 study. And exercise at least once a week decreases the risk of developing diabetes. So exercise in and of itself will help to decrease the probability of type 2 diabetes. And how's that? It increases insulin sensitivity. So we talked about type 2 diabetes having a problem with insulin sensitivity, and so with making insulin, and therefore exercise is beneficial for them, both as preventive and as treatment. What about over time? Well, the effects get better over time, as we see here with this line going down. The more weeks duration of exercise, systematic review shows that you get a downward trend and you get a stronger effect the more weeks that people were participating in exercise and reduction of diabetes. So we see that exercise stimulates the uptake of glucose, it improves insulin sensitivity, reduces body fat, and increases sense of well-being. It's one of those things we should be pushing for. We all know that we need to emphasize and push towards decreasing sedentary activity, especially in type 2 diabetics. And we want to help them and really kind of decrease prolonged sitting, have them get up to light activity every 30 minutes, which can be helpful for diabetes. And these are our normal kind of grades, where C is there's good evidence, not super strong. Grade A is there's outstanding evidence, as we're aware. And this is all from the Diabetes Care 2016 publication. Physical activity in type 1 diabetes. Youth and adults with type 1 diabetes can benefit from being physically active, and activity should be recommended to all people with type 1 diabetes. Blood glucose response to physical activity in all people with type 1 diabetes are highly variable. So you really need to make an individual plan and adjustment. We'll see that as we go along. So what also do we know? Well, we know that exercise in type 1 diabetics doesn't improve hemoglobin A1Cs as obviously as it does in type 2 diabetics. There's numerous studies where the aerobic exercise does not make a big dent, because the problem isn't insulin sensitivity, it's the fact that type 1 diabetics don't have insulin. So it's more of an adjustment of their insulin to match the exercise. We do note that the studies that do show improvements in hemoglobin A1C in type 1 diabetics really seem to, resistance exercise seems to be more effective. And we'll talk about that. Major benefit from exercise is reduction in cardiac risk factors, and that's why we should be recommending exercise to our type 1 diabetics. So the training effects in type 2 diabetics, you get acute exercise, you get insulin sensitivity, endogenous glucose production, and improvement in fasting glucose. With exercise training, we see this over time, that insulin sensitivity and endogenous glucose production improvements. And so the longer periods of time, you get more and more effects and stronger duration effects, but you also see effects initially with acute exercise. So a combination of aerobic and resistance exercise training may be more effective in improving blood glucose control than either alone. This is especially effective in the type 2 diabetics. This combination of aerobic and resistance exercise is better than each individual one. Mild forms of exercise, including Tai Chi and yoga, as you'll see in our position statement, do have effects, and yoga in itself has been shown to have an effect. There are mixed results, but more studies have come out since this 2010 paper showing that yoga can be helpful in diabetes as well. Also, in your older type 2 diabetics, so people with type 2 diabetes who want to stay active, yoga can also be helpful for balance. So some exercise physiology. When we're in our light exercise phase at 25% VO2 max, there's a very small portion of that comes from the muscle glycogen portion. Whereas as we get into moderate exercise and into severe or vigorous exercise, we see a larger part of a muscle glycogen formation. And so the fuels used during exercise really makes a difference in how you take care of your athletes, whether they are weightlifters, whether they are sprinters, whether they are long distance runners, soccer players. It all depends on where they're going to sit in that realm of vigorous and moderate exercise through their activity. So blood glucose uptake into muscle occurs in two ways: insulin mediated and contraction mediated. They're two mechanisms separately but additively using GLUT4, and thus active insulin levels affect blood glucose response by exercise by decreasing blood glucose levels more. And so you get this effect of glucose comes through, you get the insulin receptor here, and then it upregulates glucose transport through, And then also GLUT4 comes to the surface with exercise and AKT. And so there is an effect of exercise contraction, muscle contraction, not only insulin receptors. So physical activity increases glucose uptake into muscles, and it's balanced by the liver, which makes glucose production. And so there's this greater reliance on carbohydrate to fuel. And these are important. I think this is what we want to look at as we take a look at our, and we increase our VO2 max. We get into this area of moderate exercise where we start using up more and more of our muscle glycogen, and we have less of our plasma-free fatty acid being used. When we do exercise and do duration of exercise, it's going to make a difference to whether or not we get into the overproduction, and when we use our creatine phosphate and use that system. So sprint athletes really pay forward their glucose usage, and they don't need necessarily that insulin adjustment. And we'll show you that on a table that you can use. So insulin stimulated blood glucose into skeletal muscle predominates at rest and is paired in type 2 diabetics. So people with type 2 diabetes, and while muscle contraction stimulates blood glucose transport via a separative mechanism, it's not impaired by insulin resistance. So GLUT4 is really important for type 2 diabetics. And so muscle contraction, muscle activity is very important to control blood glucose for type 2 diabetics. So physical activity can result in an acute improvement in insulin action lasting up 2 to 72 hours. Why is that important? Because when we're taking care of our athletes and we see that they have fresh first-year person comes to school and they start doing an activity at a new level, they're going to have this increased insulin action. And so that when they are more likely to develop hypoglycemia, we need to be aware of changes in exercise and activity to match that, and note that the hypoglycemia can occur, especially in the overnight period of time, in our athletes who are changing from one to another. So muscle and glucose. Both aerobic and resistance training improve insulin action, blood glucose control, and fat oxidation and storage of muscles. And resistance exercise enhance skeletal muscles. So the more muscle glycogen, the more muscle glycogen, and you get more stores of glucose removed from the blood. And after exercise, you have more places to deliver that glucose to. And therefore, the muscle acts as a glucose sink. And this is why we think that when we see athletes who do resistance training with type 1 diabetes, they have better chance of lowering the hemoglobin A1C, because the muscle acts as a sink. It pulls more muscle, more place for the glucose to come out of the bloodstream and be stored in the muscle itself. How about sprinting and glucose? So short burst exercises, less than 2 minutes, they use our ATP and creatine phosphate. And so for a lot of you out there who've heard people talk about using creatine, it's those short burst activities that it benefits, because that's when you're using that phosphate to be pulled off and be redistributed to the cyclic AMP. So you get this feed forward control, immediate rise in glucose, but increased insulin sensitivity. Longer exercise uses glucose, and you get normally with exercise, and this is something for you to keep in mind, and it's often one of those questions that's asked, is what happens to insulin when a person normally exercises and does a longer activity of an hour, like a soccer match? Their insulin will decrease. So a person without diabetes, their insulin normally will decrease with their activity. And so when you're taking care of someone with type 1 diabetes, you need to match that. Their bolus insulin will decrease, and so therefore you should match that for them. This here, I always find this an interesting table. as it looks at the ATP creatine phosphate, and you can see why people can sprint that 100 and 200, start to fade off in the 400, and people sit in the 800, and then once you get up into the 1500s and above, you get a different type of athlete. So some insulin is needed to moderate the effects of glucose rise in hormones with activity. And so you need some, and so having no insulin can be detrimental in these cases. The other thing to keep in mind when you're taking care of athletes is that some practices happen in the morning. And so cortisol and growth hormone are higher during morning exercise. And so there's going to be more insulin resistance. So these period of times, you may find that you have an athlete who practices, I'm going to continually say soccer, but soccer in the afternoon, and they're fine. And then they come up in the morning, their insulin numbers are higher. That's because their counter-regulatory hormones are different, and they may need to make adjustments for morning exercise. So hormone release is intensity dependent. So this is one of those ones where we get to with stress, game time, a little different than practice. And so sometimes glucose numbers can rise with those counter-regulatory hormones during games and intense championships and things like that. So high adrenaline activity sports with intense bursts, sprinting of any type, heavy weightlifting, scary activities such as hang gliding, downhill skiing, intense competition, mental stress. What about endurance? People finishing running marathon or 10K. Extended exercise results in decreased blood glucose levels if any insulin is on board, and pre-exercise shorter rapid-acting insulin doses will likely need to be lowered. And so you need to match that. And so it's important that you make an adjustment to the insulin levels when someone is doing these extended endurance exercise activities, and that there's monitoring in place. So aerobic versus anaerobic activity, there is a metabolic difference. Blood glucose is easier to maintain during short, intense exercise. Longer duration activities generally necessitate greater regimen changes and monitoring, and increased muscle mass improves insulin sensitivity overall. So this one's interesting. As you see is that, this is resistance exercise here in this, the diamonds, and you get this drop, but not nearly as much drop as aerobic. And then you can get a nice level versus fluctuation versus control. So you will see that aerobic exercise, will get a drop much more than things like resistance exercise. You'll get a nice steady, stable after, where you might get fluctuations with your aerobic exercise. What can you do about this? Sometimes people look at like what can be done about that, and what happens when we do sprints exercise. So these intermittent, high intense intermittent exercise versus like a moderate exercise. And what we see is a drop in glucose in moderate exercise, and sometimes a late drop in the glucose levels. Whereas those sprints where people are doing 4-second sprints every 2 minutes, almost like a Tabata type program, you end up with a drop, but not nearly as much as the moderate aerobic exercise, and then stable post-exercise. So these are the things that you need to be aware of, how exercise affects glucose levels and insulin levels, so that you can prescribe these things better and understand what different levels of exercise, how they use glucose, so that you can have a better understanding of how to adjust. So now let's talk about exercise in people with diabetes. So pre-exercise clearance is generally unnecessary. Now this is different than like a decade ago. So for asymptomatic individuals to do low or moderate intense physical activity, not exceeding the demands of brisk walking or everyday living. So Moderate exercise is a brisk walk with purpose. So we're talking, the 4 miles per hour kind of walk, which is enough to get us our benefits. So if we're looking at cardiac benefits, a brisk walk is enough to give people cardiac benefit 150 minutes a week with the extension of expected life. So you as a physician, what should you ask? What questions do you need to be aware of when you're taking care of your patient with diabetes? So does the athlete notice performance changes at different level of glucose? So asking your athletes about that, what are the attitudes, abilities, and willingness of the athlete's teammates and coaches to assist them in diabetes management? This is important because you're sending somebody out, and if they're going to exercise and they don't have support for people willing to have help with check, you may need to talk to the coaches. You may need to talk to not only the athletic trainer on the team, but the assistant coaches, knowing that this person may need a moment to check their glucose levels to make sure they're fine, and that not panic. A lot of times I see people are panicked. The people with diabetes have dealt with it a lot. They're usually very good at managing their glucose levels. And you get a lot of people, coaches, and athletic trainers who are very worried about ending up having somebody with hypoglycemia. So education may be there if the attitudes and abilities and willingness of the athletes, teammates, and coaches aren't there. Do the athletes routinely monitor their blood glucose, or they use the general gestalt of how their body feels? So this is an important question to ask someone. Do you, regularly monitor, or do you just use your kind of general feel? If they're using their general feel, they're more likely to fall into a period of hypoglycemia. And so really, talk to them and negotiate about when they end up at a new level of activity and are going to be doing vigorous exercise versus moderate, that this is the period of time that we really want to start to do some blood glucose check, especially prior to exercise and during exercise. And then how do they notice, how much does it vary with life stresses and meal times, changes in training regimens and competitions, et cetera. So the rationale for screening and patients has been historically bet on the risk of acute cardiac event. And they found that for low and moderate exercise, the benefit of exercise outweighs any chance of cardiac risk. So who should get? Anybody who says they have chest pressure, chest pain, people who want to go from sedentary to a vigorous program. And vigorous is running, so somebody who wants to run a 10-minute mile or faster, those people need to have a check. And individuals who are increasing from sedentary, as we said, to more vigorous. Highly recommend that individuals with type 1 diabetes get diabetic retinopathy checks before resistance. So anybody who's going to Valsalva, anybody who's going to do heavy weightlifting, where they may end up having to Valsalva while they lift, which you're not supposed to do, but people do. Getting retinopathy checks and getting a digital dilated retinal examination can be very important and should be done. So training effects, so we said blood glucose use and fat use increases, thus less muscle glycogen used after 2 to 3 weeks of training. And so you may get a change in your need for insulin as the person gets better and better affected with their training. So as you go from middle school to high school to college, or JV to varsity, these big changes, and you're now moving to a new level, you're going to have an adjustment as they get their training effects over 4 weeks, and they make these adjustments that you're going to need to be aware that they'll need to make adjustments to their insulin levels as they decrease their blood glucose use. So regular exercise improves blood glucose control, lower insulin doses needed. We talked about this just before. And we talked about morning. So mornings, you may need to have more insulin. So you need to monitor and know when they are having troubles with their glucose levels. Stress. So as we do activities like the start of a triathlon, which is a free-for-all, and there can be a lot of stress involved as you get your head dunked under the water. It's important to be aware of the fact that stressful situations like exams, etc., can affect glucose control. You know, I've seen this, and I keep this in my presentation, but I personally have not noticed, and having taken care of athletes with diabetes, I've not noticed a big difference in the second half of the menstrual cycle in teens and women, but it's there because of progesterone. And so hypoglycemia, moderate aerobic exercises improve blood glucose and insulin action. And so transient hyperglycemia can follow intense physical activity, but you can get a drop in glucose levels for at least 24 hours after exercise. So it's really important to monitor, and I have people who are jumping from one level to the other, monitor at night. This is where continuous glucose monitors are quite helpful and can be useful. So hypoglycemia, shaking, sweating, anxious, dizziness, hunger, fast heartbeat, impaired vision, weakness and fatigue, headache, and irritability. What's the difficulty? Most of these things are when you're running really hard and you're fatigued from practice and near exhaustion anyhow, these can show up. So there's a little difficulty in being able to differentiate those things. Obviously, the one that I've always found is irritability, and some people are always irritable, ask my fellows, and then shaking. So those things are ones that really kind of stick out to me. Hypoglycemia is serious but avoidable condition. So have an emergency action plan and practice it. Get your emergency action plan and practice it. Hypoglycemia can occur during exercise or early after exercise. So seen more often in unchanged insulin dosing and also with sulfonylureas prior to exercise. The other medications really aren't associated with this hypoglycemia, but SLG2s, they can enhance this with the insulin and sulfonylurea, so they can amplify that. GLPs have a direct connection, and exercise actually can make GLP2s work better. So I said two, work better. So there's some new studies showing that exercise with those can make those more effective. Hypoglycemia, blood glucose less, is the most immediate risk during and after exercise. You really need to have access to simple carbs, and a glucagon emergency kit are very important. All your diabetics should have a glucagon emergency kit. All your diabetics should have a glucagon emergency kit, and preferably two, one for their athletic trainer if they're in college or at a high school with an athletic trainer, or their coach if they're not that, with an athletic trainer, and then one for them. And I've had numerous athletes who, end up going out drinking because they're in college, and they end up with hypoglycemia. And it's great that they had one there. I had at least one where a roommate gave them glucagon. So it's important that roommates know about it as well. Most common following long duration or repeated bouts of high intensity exercise for delayed onset hypoglycemia caused by a combination of enhanced glucose action and muscle glycogen repletion. As we talked about, can happen delayed, but usually 6 to 12 hours. So evening exercise is the highest risk for hypoglycemia overnight. So evening exercise, highest risk for hypoglycemia after in the overnight. And I say that twice because I saw that on the CAQ recently. So what is one of the interesting things that people are experimenting and figuring out is that a 10-second sprint at the end of an exercise session. So this is a 20-minute exercise session. Then they did a 10-minute sprint. And they saw that the people who did the 10-minute sprint did not get a drop in their glucose levels post-exercise versus people who did vigorous 20 minutes of exercise without the 10-minute sprint did have a drop in their glucose levels over the next 2 hours. Prior hypoglycemia is very dangerous. So the person who has a hypoglycemic episode the day before, for the next 24 to 48 hours, they are at risk because they just dumped all their glucagon. They're at risk for another hypoglycemic event. I will sit the people the next day. If they had a serious enough event where they went hypoglycemic and you needed to treat them, I sit them the next day, just like if you had a concussion or some other type of injury, so that they can regain their counter-regulatory hormones. Always good to have a glucose source with you. One of the ones that I like having is cake frosting. It comes in those nice little squeezy tubes with a little twist. They now make glucose ones like that, and you can just put it in their buccal. You can put it in other places, but it's very useful to have the cake frosting. And then, right before it goes expired, you can always use it yourself if you like cake frosting. Remove athletes and activate the emergency medical system. And then if they really are unresponsive, make sure you use a glucagon injection. And when they come back around, they still need to go get monitored. Don't just put them back on the field. Just like somebody had a bad allergic reaction and they get angioedema, you give them epinephrine. It's just to get them to the hospital, not to send them on their way. So continuous glucose monitoring during physical activity is important. So what will happen is as someone that starts exercising, may get a slight rise in their glucose and then they'll get a drop. And you want to monitor it so you can measure it, see that drop, catch it before you get to the nadir, so that you might need to make an adjustment in their glucose levels. You might need to drop back on the bolus insulin, might need to give them some glucose. So that's where continuous monitor can be helpful. And when they look at continuous glucose monitors, they fall on this 99 to 100% fall into the zone A, zone B, which means they're highly reliable to finger stick glucoses. And so these are during high intensity exercise and continuous aerobic exercise. This is a lot different than the ones 10 years ago. So things to keep in mind, they might be inaccurate and very cold and high altitude. So like mountain climbing activities, or if you're going up to Wyoming to play football, you may need to switch over to finger sticks. This is a glucose machine. Never used one, go ask your MA or nurse in your clinic to do one and do a finger stick and measure your glucose levels, because you may have an athlete you're going to need to do a finger stick with on the sideline. Don't let that be the first time you ever use a glucose monitor. Highly recommend that you go test it out yourself for the first time. Do a finger stick on the sides, on your finger. On the tip of your finger, and then squeeze a drop onto a pad, and you slide the pad into the machine, and it'll give you your measurement. So when you monitor beforehand, if they're below 90, you want to try to delay exercise, give them some glucose, and then start to drop their bolus. If they're in that 90 to 124, ingest 10 grams of glucose. So an apple is 80 calories or 20 grams. So just keep in mind, a cheese sandwich on white bread is around 20. So start glycemia at target level. So 126 to 180 is good for aerobic exercise. Once they're above 180, you're going to start getting dehydration, as you probably remember, that all glucose gets filtered through the kidneys and then reabsorbed in the kidney. And that's where the SLG2s block that, and you pee out glucose, which makes you dehydrated. So that's one of the downsides of that product in athletes. And so the important part here is that when you're in that 182 to 270, really need to be aware that these people can run into problems that the athletes may start climbing. So you need close monitoring. And then above 270, really want to check for ketones. and try to restrict, get their levels down. So hyperglycemia can accumulate from intense exercise. Once you get up above 250, 270, depends on who you read, then you want to look, you're in a state of insulin deficiency. You want to check for ketosis. You want to start to add your insulin to them and get them down into the more favorable range for exercise. If they're over 300, you should use caution and not to have them exercise until they get into better control, so that you are very low on your insulin. And then when you exercise, your counter-regulatory hormones are going to kick in. You can throw somebody over into a ketoacidosis if they're type 1. Hydration is important. So it's very important to keep hydrated, because you can get dehydrated easily, especially if you're start to climb. If a type 1 patient with type 1 diabetes starts climbing to the 180s, they're going to have glycosuria, and they're going to have an osmotic diuresis, and so therefore they're going to become more and more dehydrated. So it's very important to stay hydrated. This is important for everybody, but very important for type 1, type 2 diabetes, sickle cell trait, all those ones. These medical conditions, very important to stay hydrated. Hyperglycemia increases risk, and 1% to 2% of body fluid's already lost when thirsty. So if you want to be drinking, whether or not you think you're thirsty or not, you want to make sure the athlete's doing that. You can use your water bottles. I think one mouthful is about an ounce of water, and it's very important to keep hydrated throughout activity, especially for athletes with diabetes. So additional carbohydrate intake after exercise can be helpful and important to prevent the hypoglycemia, and also to replenish the muscle glycogen stores. So remember, it's type 1 diabetes. Diabetes is not too much sugar, it's too little insulin. So just like athletes, they benefit from post-exercise glucose to restore muscle and decrease delayed onset muscle soreness. So your insulin pump needs to make adjustments. So bolus reduction is needed. Ideal for exercise lasting more than 60 to 90 minutes. And so you want to decrease that bolus, that amount. And so mild aerobic exercise is a small reduction, and moderate is a 50% reduction. Heavy aerobic, so vigorous exercise. The difficulty when we look at like soccer, for instance, like you mentioned, is that it's a walk, run, sprint. So most of the time you're actually sitting in that walk range. So most people try the 50%, like those type of sports, versus like cross-country skiing or where you're sitting in that, or biathlon, where you're sitting in that 70, 75% VO2 max, frequently. Over here, where you say not applicable, because if they're doing 60 minutes worth of heavy aerobic, they're going to wear out and won't be able to. No reduction for sprint activities. As we talked about, it's a paid forward mechanism. So disconnect bolus. So often athletes can't wear, like swimming. We had Michigan people, so Michigan hat there. And so that bolus, the insulin will drop over time. So you have that insulin level, and it has a half-life. And so over the next couple hours, that half-life will go down. You may need to reconnect when it's checked and give yourself a little bit more bolus with adjustments. I keep saying you, but patient. And so it's important to, if you're using a disconnect from the bolus as a way of tapering down your insulin, to check the glucose levels with the finger stick or the continuous monitoring, so that you know when you might need to add a little more bolus or a little more insulin as you start to climb, if you become too low in insulin, because you do need some insulin. Structured lifestyle interventions. Remember, as we said, daily activity is very important for diabetes. And so not only is regular aerobic exercise, but resistance exercise in addition. And that's important for your type 2 diabetics, is that aerobic and resistance, those combination is the best for reducing hemoglobin A1C. And so there, and with type 2 diabetics, different things like step counters and internet delivered mechanisms can be helpful to help target behavior changes. Here's some internet resources for you. Diabetes.org, food and fitness, and then diabetes.co UK, exercise for diabetics. Both good internet-based ones. Obviously, we're coming out with our position statement, which should be published very soon in the next couple of months, and highly recommend that as well as Sherry Kohlberg. If you want to read anything by her, including her books, if you're really interested in diabetes and exercise and diabetes, her books are great, and I always love working with Sherry. So what did you learn today? The benefits of exercise for type 1 and type 2 diabetics, that type 1 really is resistance, type 2 exercise plus resistance even better. More muscle sync, the better. More muscles are good for type 1 diabetics. The effects of exercise at different glucose levels. Sprint exercises don't need much of adjustment. When you get into those longer durations, you got to decrease the bolus. Methods to prevent exercise complications. We talked about that, having a plan. Having your EAP is very important. Emergency action plan, very important. And what were the symptoms of hypoglycemia, including shaking, irritability, sweating, blurred vision, all those things. When they start to come on, you need to start checking blood glucose levels and start your treatment of hypoglycemia. I like the cake frosting too. Those tiny small ones, very useful. And I give you your web sites, and good luck. Questions? Right there, 45 minutes, right on the mark. Told you, Dana.
That was perfect. Thanks,
I know,
Dr.
right?
Trojian.
If nothing else.
I felt you gave a lot of good, important considerations, and then I learned a lot about different types of exercise, how they affect your glucose levels and A1C for type 1 and type 2. So thank you. To start out, what would you say is the most challenging aspect of managing diabetes in athletes?
Coaches and athletic trainers. Because everybody's worried about somebody becoming hypoglycemic. And, so I find, you need to really work with them and let the athlete be an athlete and be a human.
Yeah.
And they're a person, and they have this, they have a problem. They're not, don't let their illness define them. I think that's the important aspect. Just like somebody with sickle cell trait, we have to be careful that we don't let the illness define who they are, because we've found, there's higher prevalence of sickle cell trait in Olympic athletes than there are in the general population. So it doesn't seem to inhibit people from being able to be excellent.
Yeah. We have a question from Edwin. Aside from holding someone out who had a hypoglycemic episode in the preceding 24 hours, are there any other return to play recommendations that you have?
Looking at why. So, explore what their day has been. It's most often it's because they have been a college student. Most of the time I get it because when you're in high school, they don't usually show up, on the sideline. It's happens and you're not there. But in college, it's because they have been getting busy with studying. They've been staying up late. And we talked about stress plays a big role in these things.
Yeah.
So stress and lack of eating and so just making sure you look through it and figure out, why did we end up hypoglycemic? Where did we start off low? Did we not check our glucose before the event? that's the big thing. Your period of time is so short that they're not going to become deconditioned or need a 5-day return or anything of that sort. It's more of like they are at really high risk of becoming hypoglycemic again, and that's not good. So that's where that 24 hours, like they had it, it's more like a day. So I don't let them go the next day. So it ends up being almost 48, if that makes sense. Because I use like a day, because I don't, like you'll get a coach will be like, well, we practiced at 5 yesterday, so we should be able to have them go at 5:01 the next day.
In like, speaking of checking your blood glucose, in your experience working with athletes, how many of them had like continuous glucose monitoring versus would check like before, maybe middle, after games, or just the going by symptoms?
So yeah, the continuous glucose monitoring, the good ones are very recent. So, the last. So my experience or my extended, I'm old. And so has always been continuous, been regular finger stick monitoring and use of long acting, bolus with pumps, and became really great, one person put it here, that we were talking about with the athletic trainer and the coaches, that they did most of the management. And I think that's true too. You have to remember your athlete with type 1 diabetes knows a lot more about things, than the coaches and athletic trainers. So let them tell you and talk to you and communicate with you. So every one of the questions, Dana, in here, what they found to be helpful. And I think those questions that I said, those 4 questions, are really important with things. And educating the coach and the athletic trainer that they'll be okay. And so, and letting the athletes do their monitoring and checking.
So I guess to sum up your answer for how involved the physician should be, like, kind of depends how well the athlete is already managing.
I mean, I think the difficulty too is that, the person asking the question here in the chat is that when you're taking care of an athlete when they go to high school or college, and the parent, is going to be involved too, because they've been taking care of this. And there's very few athletes who their diabetes became better controlled when they became a first-year person in college, when they didn't have their parents sitting around, and they gained a little independence. So it's important to kind of keep an eye on things, but also not overwhelm them,
I had one. I was reading the current sports medicine, one of the papers that you had contributed to, and I think at the end it said that diving and mountain climbing should not be, or having diabetes is not a contraindication to that. Is there a specific reason why, I guess, those sports in general in the past were considered?
It's hard to, if you're doing scuba diving and diving deep, you're kind of limited in your blood glucose monitoring. And so, those are hard. And then too, mountain climbing, where are you keeping your insulin? It's like milk, it's going to freeze, and it's going to spoil. And so you've got to keep in mind that, it's a protein in suspension. And so that's why I say it's like milk, it's a protein in suspension. So if it freezes, you got to keep all these things in mind. And so it makes it more difficult, but it's not counterindicated. You just have to, keep things in perspective and be able to do those things and plan ahead. So they had been recommended against because of the fact that it makes it really kind of hard. But if you plan correctly, people have done it successfully.
Good. Well, thank you again. Really appreciate you taking the time to do this. I echo Nate and I's statement here on behalf of the Fellows Online Education Subcommittee and the Fellows. Thanks so much for sharing your expertise.
My pleasure. And good luck to everyone. And feel free to, if you have any questions, feel free to send me an email at ttrojian@wellspan.org. So.
And we have that SurveyMonkey feedback form about the lectures that Andy sent in the chat if you haven't filled it out already.